Welcome, my fellow YouTubers, medical students who have joined me here, to discuss this topic, meningitis, right? So, let's discuss meningitis. So, let's move on to the next slide. Meningitis. Meningitis, by definition, is the inflammation of the meninges, but not all three meninges, right? Specifically speaking, the leptomeninges, namely the arachnoid and the pyometer, right? We know that the brain is covered by membranes known as meninges, and there are three meninges, three meningeal layers. We have the dura mater, that is just beneath the periosteum, followed by the arachnoid mater, followed by the subarachnoid space, and beneath the subarachnoid space lies the pyometer, which closely encapsulates the brain, it is in close contact with the brain, right? Okay, so inflammation of the leptomeninges is known as meningitis, and this inflammation can either be infectious in nature, meaning it might either be caused by bacteria, viruses, fungi, parasites, or it may be, in less common cases, by autoimmune disorders or non-infectious disorders such as sarcoidosis, carcinomatosis, and systemic lupus erythematosus, right? Okay. Classification. Well, for the sake of simplicity, we can classify meningitis, on two ways, on the basis of acuity or chronicity, into acute meningitis and chronic meningitis. Acute meningitis, as the name suggests, is meningitis that is characterized by the development of signs and symptoms within just a few hours to a few days. Whereas acute meningitis is most commonly caused by bacteria and viruses. Chronic meningitis, on the other hand, is meningitis which is characterized by the onset of signs and symptoms within a few weeks to a few months. And chronic meningitis occurs most commonly because of fungi and parasites. Then on the basis of cause, we can classify meningitis into acute bacterial meningitis and acute aseptic meningitis, which is caused by non-bacterial microorganisms, namely viruses, parasites, and fungi, right? We know what the meaning of sepsis is, right? Sepsis is basically a condition in which bacteria are present within the bloodstream and they are rapidly multiplying, right? Rapidly multiplying, resulting in bacteremia, and bacteremia, when it tries to infect organs, right? When it tries to flood the organs and infect them, it results in septicemia. So sepsis essentially and most commonly occurs because of bacteria. So that is why we label meningitis due to viruses, parasites, and fungi, under colloquially with the term aseptic, right? Okay, causes. Meningitis, like I mentioned previously in the previous slides, can be caused by bacteria, viruses, parasites, and fungi. But most commonly, in the majority of cases, meningitis is most commonly due to bacterial infection, right? Bacterial infection. And the bacteria that cause meningitis differ, in different individuals, in different age groups. In neonates, the most common bacteria that have been implicated on the basis of research to cause meningitis are Streptococcus pneumoniae, Listeria monocytogenes, and Escherichia coli. You'll simply just have to remember the names of these organisms, just memorize them. There's no rocket science, to them. There's no concept. In children plus adolescents and adults and the elderly, the bacterial organisms that have been implicated to cause meningitis are strep pneumoniae, Neisseria meningitis, most commonly, Haemophilus influenzae. This one is very important. Haemophilus influenzae, Listeria monocytogenes, right? Okay. Viruses, fungi, and parasites most commonly cause chronic meningitis, and these are overall the least common causes of meningitis. And the least common organisms, microorganisms that can cause meningitis. Viruses that can cause meningitis include the herpes simplex virus, the cytomegalovirus, the Enteroviridae family of viruses. In fungi, we have the Cryptococcus, we have the Histoplasma, and we have Blastomyces. In case of parasites, the names, although really difficult to write and pronounce as well, but you'll eventually get the hang of it once you start memorizing these names again and again. Angiostrongylus cantonensis and Belisascaris procyanus, right? Now, regardless of the organism that is causing meningitis, one would contemplate how do these organisms, enter the brain, come into contact with the meninges, and result in the subsequent inflammation and infection. Well, there are three known and most common ways through which, or routes through which, any of these organisms can, enter the brain and result in meningitis. Hematogenous spread, contiguous spread from other local nearby sites, infected sites such as sinusitis, in case of the nose, sinusitis, in case of the ear, or suppurative otitis media, right? Or one other route is via the retrograde transport along the cranial nerves, right? Yeah. So it is through these three routes that these organisms can enter the brain, pass through the blood-brain barrier, and come into contact and infect the meninges. Okay, so how will a patient with meningitis present to the clinic, right? To a doctor? Well, he will, initially develop symptoms like headache, fever, and nuclear rigidity. And these three symptoms are the classic triad of meningitis, right? These three symptoms alone are pathognomonic for meningitis and hence can confirm your diagnosis. Nuclear rigidity or neck stiffness, right? Okay. Other symptoms that can develop later on as the disease progresses, as the infection of the meninges progresses, include photophobia, which is sensitivity to light, and phonophobia, sensitivity to sound. Nausea, vomiting, delirium, and seizures in complicated meningitis, right? Because if meningitis remains untreated for a prolonged period of time, the infection can progress to involve the entire brain parenchyma, resulting in its diffuse inflammation, which is labeled as encephalitis, right? So encephalitis, will then present with delirium and seizures and altered confusional state. Delirium is basically rapid cognitive dysfunction, right? Which is then characterized by an altered mental state, behavioral abnormalities, confusion, dizziness, fatigue, disequilibrium of the body, yeah. Okay, signs. So the patient comes to you with the symptoms of headache, nuclear rigidity, and fever, right? So you immediately suspect that the patient might be suffering from meningitis, but you want to be sure. So you start with the clinical examination of the patient. So what will you examine for or look for in a patient with suspected meningitis? Well, we look, we most importantly look for these two signs, the Kernig sign and the Brudzinski sign. The Kernig sign can be elicited by asking the patient to lie down flat in a supine position, and his hips should be flexed along with his knees, right? So when you try to extend the patient's legs at the knee joint while his hips are flexed, the patient will experience low back pain. This is known as the chronic sign. And the second most important sign that can be elicited or that comes out to be positive in patients with meningitis includes the Brudzinski sign, right? And the Brudzinski sign can be elicited by simply raising or lifting the head of a patient who is, only to say 30 degrees, right? To the point where he starts experiencing even more pain in his neck because of the stiffness. So as a result, reflexly, he will bring his legs towards his chest, bring his or her legs towards his chest, as a reflex mechanism. In patients with meningitis that might be due to bacteria, such as meningitis, the patient will also, along with the specific signs and symptoms of meningitis, will present with a maculopapular rash, petechiae, and purpura. Right? If the meningitis is due to a virus, right, then vesicles will appear on the body, indicating that yes, the meningitis that the patient is suffering from might be viral in nature. This is a universal saying that if you don't treat an infection in time, it will progress, and progression of an infection will lead to the development of complications. Right? In case of meningitis, if you leave the infection untreated, then several complications will ensue, most importantly of which is the brain abscess. Any bacterial infection left untreated will eventually result in the development of an abscess, right? Because when the infection is going on, the immune system of the body remains activated and continuously produces WBCs against the bacteria, right? So the innumerable amount of bacteria and WBCs, when the bacteria and the WBCs they build up, then they will result in the development of a brain abscess. An abscess is basically a combination of dead WBCs and bacteria. Hydrocephalus, why? Because the CSF that is flowing within the subarachnoid space between the arachnoid mater and the pia mater will eventually become full of WBCs and bacteria, resulting in an increase in the intracranial pressure, right? Intracranial pressure that will lead to hydrocephalus, and that can be debilitating. Deafness and brain damage, of course, seizures because of encephalitis that might develop subsequently to meningitis if meningitis is left untreated, right? Let's move on. So how do you diagnose this condition? Because one cannot differentiate between acute bacterial and acute aseptic meningitis on clinical grounds, because the signs and symptoms in both cases are the same, right? With the exception of a maculopapular rash in case of bacterial meningitis and vesicles in case of viral meningitis, it's impossible. So how do you confirm your diagnosis of whether the meningitis is bacterial or viral or fungal or parasitic? Well, you can do that on the basis of a lumbar puncture. Which is the gold standard for the diagnosis of various central nervous system conditions, like in this case meningitis, encephalitis, stroke. So the lumbar puncture is basically used to draw CSF for the purposes of analysis to confirm or rule out a diagnosis. Once the CSF has been drawn, you assess that CSF, right? For various things like the protein count, the glucose count, the WBC count, the lymphocyte count, the consistency and the appearance of CSF, right? Yeah. The intracranial pressure, right, which I forgot to mention, is raised in meningitis. The normal intracranial pressure is 16 millimeters of mercury, 16, right? But in this case, it would be as high as 150 millimeters of mercury, which is, quite alarming. So if meningitis is bacterial, right? If it's bacterial, then the CSF will be thick and cloudy due to the presence of due to an abundance of WBCs. Normally in CSF we have 5 WBCs per microliter, right? But in bacterial meningitis, the WBC count can be as high as more than 1,000 cells per microliter, right? The protein count will be high and glucose levels will be low. Why? Because the bacteria try to use up all of that glucose that is present within the CSF in order to attain their sustenance and to keep on replicating and to keep on causing infection. In aseptic or viral meningitis, the CSF will be relatively clear, normal. There will be no turbidity or cloudiness, but there will be marked lymphocytosis, right, with an abundance of polymorphonuclear leukocytes. The glucose level will be normal. The protein levels will also be normal. The glucose levels will be normal because viruses don't require glucose for their sustenance like bacteria do. A CSF PCR can reveal viruses like HSV, CMV, EBV. But one important thing to remember before, as a clinician, as a medical officer, before performing a lumbar puncture, is to perform a CT scan, right? And the importance of performing a CT scan before a lumbar puncture in patients with suspected meningitis is to rule out any focal neurologic lesions or a space-occupying lesion, right? In which case the intracranial pressure is so high that performing a lumbar puncture can be extremely risky. Can be life-threatening even. Yeah, so once you've performed the CT scan and everything is clear, then you can move along with lumbar puncture. You'll get your CSF results back. Then on the basis of CSF results, you will then confirm your diagnosis of either bacterial meningitis or aseptic meningitis, and then you will decide the treatment plan for the patient. And the treatment plan for the patient is, we begin with steroids and not antibiotics, right? We begin with steroids, and why steroids? To relieve any raised intracranial pressure or cerebral edema, right? Okay, once you've done that, and then you'll start the patient on empirical antibiotic therapy, because we can't wait for the lumbar puncture results to come back, right? Because acute bacterial meningitis almost always presents as a medical emergency, which means that as soon as you perform the lumbar puncture in patient, you will start the patient on empirical antibiotic therapy on the assumption that the patient might be suffering from bacterial meningitis. Yeah, and once the results come back, then you can start the patient on intravenous antibiotic therapy, right? And if the cause of meningitis is viral or fungal or parasitic, then you can give antivirals, antifungals, and antiparasitics, right? How do you prevent meningitis, right? I mean, we talk about treating meningitis. How do you basically simply prevent meningitis so that you may never develop this condition, so that you may never require any treatment, right? So for that, we can give prophylaxis against common bacterial causative agents, such as against Meningitis, Streptococcus pneumoniae, and Haemophilus influenzae, right? Especially to those people who are in close contact with, infected individuals. Thank you for your time. I hope you learned a lot from this lecture, and I'll see you again with a new lecture.